Yeah, so good morning, everyone. I will take you through the diagnosis and the management protocol of a patient with ocular surface squamous neoplasia. First, the diagnosis will be 12 minutes and followed by with the management presentation. So, I will begin my presentation with a tribute to Professor von Graefe, who first described ocular surface squamous neoplasia in the year 1860 and named it as epithelioma. So we have come up a long way from there, and now the diagnosis of ocular surface squamous neoplasia mainly depends on the clinical features. I will give you 10 clinical pearls how to clench the diagnosis. Apart from that, imaging and impression cytology have some added advantage in some specific cases. Histopathology forms the gold standard for diagnosis. So moving on with the clinical features, whenever a patient, first it is the most common in elderly male in the tropical climate, more so in patients with xeroderma pigmentosa or seropositive patients, patients with hematologic malignancies or post-transplant patient. So whenever a patient with a limbal nodule walks into your clinic, you need to see the morphology of the lesion. Although these morphological types do not have a bearing on the management, it is extremely important to know about these morphological types in order to diagnose it properly. So this first type is the nodular variant of ocular surface squamous neoplasia, followed by this leukoplakic type where you see a white sheath of cells going from the conjunctiva into the cornea. Next comes the gelatinous type where it's a jelly-like consistency of the tumor cells on the entire ocular surface. Next is the papilliform variant. Nodular ulcerative type is the most recently described type of ocular surface squamous neoplasia, where you will find this area of scleral and conjunctival dehiscence, which is surrounded by a indurated and thickened conjunctiva with blood vessels inside it, like this feeder vessels you can see. So this nodular ulcerative variant many a time is confused as a case of scleritis. The diffuse variant, you will see these, if you look minutely, you will see these sheath of cells on the ocular surface, and this is most likely, most commonly misdiagnosed as cases of conjunctivitis. Next, coming to the location, it is most common in the interpalpebral region, the epicenter being at the limbus. You need to look for the intrinsic vascularity. There are these loop-like blood vessels inside the mass. Keratin. Keratin is an extremely important indicator of ocular surface squamous neoplasia. Whenever you see keratin on the ocular surface, please rule out ocular surface squamous neoplasia. Feeder vessels. So what are feeder vessels? Feeder vessels are dilated, tortuous conjunctival vessels which dip into the lesion. So feeder vessels are very important features of OSSN. So you need to see whether there is any corneal component to the lesion. If present, the management, you will have to add alcohol keratoepitheliectomy to it. So the corneal OSSN is very different from the conjunctival form. So how does a corneal OSSN look like? If you see this patient had a OSSN which was limited only to the conjunctiva. So if you see, it is like a ground glass sheet of cells on the conjunctiva, on the cornea, but the most important diagnostic feature are the edges. If you see the edges, they are either heaped up, like in this case, or on high magnification you can see these fimbriae-like projections at the edge. So another good way of diagnosing corneal OSSNs are this apparently normal cornea on a cursory examination. When seen on retroillumination, you can see the fimbriated edges present, and thus this was a case of corneal OSSN. Next, we need to rule out any intraocular extension, and this can be found out by moving the lesion with the help of a cotton-tipped applicator. If there is a scleral fixity, that is an indicator of intraocular extension. This can further be confirmed on the ultrasound biomicroscopy. Next is the orbital extension. If any any border of the lesion is not visible to you clinically, you need to go ahead and do a CT scan in order to rule out an orbital extension of the lesion. As you can see in this case, there is a inferomedial orbital mass here and extending into the insertions of the medial and the lateral rectus. Pigmentation. Pigmentation is again an important finding in ocular surface squamous neoplasia. Thus, all these findings needs to be documented in all cases, and it's good if you can pictorially depict it in your OPD. All the findings like the location in terms of the dimensions, the clock hours needs to be mentioned, presence of corneal component, whether intrinsic vascularity is there or not, feeder vessels, keratin, scleral fixity, and also presence of any regional lymph node needs to be mentioned. Moving on to the imaging part, whenever there is a doubt in the diagnosis, we can go ahead and do a anterior segment OCT. So how does a OSSN look on anterior segment OCT? So OSSN, if you see here, it has this typical appearance of a hyper-reflective thickened epithelium which has an abrupt transition into the normal corneal epithelium. Again, the ultrasound biomicroscopy, you can see the tumor going inside the, traversing the cornea and going inside the Descemet's membrane. Cytology. Impression cytology refers to the placement of this cellulose acetate paper on the ocular surface to pick up superficial cells on the ocular surface, and it can only indicate whether dysplasia is there or not. So impression cytology has a very limited role in cases whether we are in a dilemma in diagnosis, or in cases of recurrences, or may be used to assess the response of topical chemotherapeutic agents. So it has the advantage of being easy, simple, with a high positive predictive accuracy, minimal discomfort to the patient. However, it requires a skilled, experienced cytologist, and it has limited role in keratotic lesions, as the keratin may interfere with the sample imprinting. So the differentials which you need to consider while considering your diagnosis of OSSN are actinic keratosis. Actinic keratosis usually appears as a plaque with keratin on it, but it may be away from the limbus, as you can see in this case, and there are no feeder vessels as seen in OSSN. Squamous papilloma. Squamous papillomas are many a times extremely difficult to clinically differentiate from a case of OSSN, and histopathology can be the clincher in these cases. Pyogenic granuloma is a vascular, many a times pedunculated lesion bleeding on touch. They usually have a preceding history of surgery or trauma. Limbal dermoid is like a very well-defined whitish grayish lesion, usually present since birth with no feeder vessels or any vascularity. Conjunctival melanoma is a tumor which can masquerade a OSSN. Here you can see there are two nodules to it. One is a amelanotic one and the other is a melanotic one. But the important differential with OSSN is the presence of keratin. Keratin is not there in patients with conjunctival melanoma. So with this, I will move on to my presentation of management of OSSN. Okay, so having diagnosed a patient to have ocular surface squamous neoplasia, for managing the patient appropriately, we need to simply classify the patient in the clinic, whether is it a localized form or is it a diffuse or extensive or giant form of OSSN, or is it an invasive form. So the localized form will include a corneal OSSN where the tumor is only located on the cornea, and I have already told you what are the clenches in diagnosis. You need to see at the edges. Next comes the conjunctival or the conjunctival corneal OSSN. This is the most common type of OSSN which you see in the clinic, the conjunctival or the conjunctival corneal form. Or is it an diffuse or an extensive OSSN? So we call a OSSN to be diffuse if the greatest dimension is more than 15 millimeter, or the limbal extent is more than 180 degrees, or that is 6 clock hours, and they usually have a flat configuration. So this is the diffuse variant, or it can be invasive. Invasion can be both intraocular invasion or a orbital invasion, as you can see in this case. So having classified our case of OSSN into these three varieties, what are the management tools we have in hand? So the most commonly employed method is a tumor excision with cryotherapy. The second is topical chemotherapy, plaque brachytherapy, and destructive surgeries like extended enucleation or exenteration. So when it is a corneal OSSN, the most commonly employed treatment is interferon alpha 2B drops, and or you can also do a alcohol keratoepitheliectomy. I will come to it. So conjunctiva corneal or purely conjunctival OSSN most commonly, and the mainstay of treatment is excision biopsy with cryo. Diffuse OSSN, the best treatment modality is interferon alpha 2B injection with drops, and maybe the newly reported in literature from our center, combining a simple limbal epithelial transplant along with our routinely done excision biopsy with cryo can help. In invasive cases of ocular surface squamous neoplasia, whenever there is an intraocular extension, yes, plaque brachytherapy is an option, but otherwise you can do an extended enucleation. For the orbital invasion, orbital exenteration needs to be done. So coming to the most common type, a conjunctival localized tumor. So what we do is a wide excision biopsy where we take 4 millimeters of clinically normal conjunctiva on the conjunctival side, and if there is a corneal component to the lesion, we also do a alcohol keratoepitheliectomy including 2 millimeter of clinically normal corneal epithelium. Then we do a double freeze thaw cryotherapy to the normal conjunctival margins, which is followed by surface reconstruction. In my practice, I prefer doing a amniotic membrane transplant. You can also do a primary closure or a conjunctival autograft. So I will show you a short surgical video. To elaborate on this surgery. Okay, so the surgery, we follow a no-touch technique for ocular surface squamous neoplasia excision. So a no-touch technique basically means we make a strict attempt not to touch the viable tumor cells throughout the surgery to prevent tumor cell spreading. So the surgery begins by marking the conjunctival Surgery begins by marking the clinically normal conjunctiva 4 millimeters. So this is the area we will have to remove, 2 millimeter on the corneal side. After that, I do with the help of a bipolar probe, I am cauterizing the conjunctival edges. This reduces the bleeding during the surgery. So this is the excision of the tumor from the scleral bed. This needs to be done very gently. Yeah, so the removal of the tumor from the bed needs to be done very gently to the undersurface of the tumor so that there is no tumor cells left on the bed. This is, I am marking the 2 millimeter area with the help of a crescent blade, followed by application of absolute alcohol with the help of a surgical sponge, which revitalizes the corneal epithelium. It becomes gray. Then you, with the help of the same crescent blade, you can nicely scroll it up on the lesion. So the next step is cutting this is again showing the tumor is being lifted from the scleral bed, cutting the tenons. This step is extremely important where we are cutting the tumor at the limbus using the scissors. Care is taken to keep the scissors flush to the scleral bed in order to avoid any residual tumor on the bed. Then on a Whatman filter paper, it is nicely placed flat, maintaining the proper orientation. Hemostasis is achieved with the help of bipolar probe. Then the margins are being taken to be sent separately to the pathologist. The margin needs to be placed on the same Whatman's filter paper, marking nicely. Then the next step is the application of the double freeze thaw cryo. The cryo, it is given applied through the undersurface of the conjunctiva, pulling the conjunctiva up so that the underlying sclera or the ciliary body is not frozen. Then the surface reconstruction is done by placing an amniotic membrane graft and sticking it to the underlying sclera with the help of fibrin glue. It can be placed flat with the help of the iris repositor. So this is a clinical photograph of a patient before and after surgery, but results are not this rosy every time. In cases of diffuse ocular surface squamous neoplasia, if you go ahead and do a tumor excision, it can lead to limbal stem cell deficiency, which may cause pseudopterygium formation or symblepharon formation. So what is the way out for these tumors? So the newer trend for these tumors is to go ahead and do a topical chemotherapy. Topical chemotherapy consists of 5-fluorouracil or mitomycin or interferon alpha 2b. However, with 5-fluorouracil, the side effect profile is pretty high. 60% of the patients are reported to have surface side effects like lid toxicity causing entropion or ectropion, SPKs, corneal epithelial defects, punctal canalicular stenosis. With mitomycin also, conjunctival congestion happens in 60% of the patient. There can be conjunctival chemosis, SPKs, punctal stenosis, limbal stem cell deficiencies. So the efficacy of all these three agents are comparable, but considering the side effect profile, interferon alpha 2b is the safest of all. So interferon alpha 2b is a glycoprotein produced by recombinant DNA technology. The exact mechanism of action is unclear. These are the different proposed mechanisms. So I will take you through a video where I will show you how to prepare the interferon eye drops. It is easily available in the market, prepared by Intas. It costs only 800 rupees per vial. So this is the pre-filled syringe, this 5 million international unit. It has a 1 ml interferon alpha 2b in it. I am in a sterile environment. I am placing it inside the vial. Then I am taking distilled water 4 ml. So 1 ml interferon alpha 2b is being mixed with 4 ml of distilled water in a sterile environment. This forms 1 million international unit of interferon alpha 2b. You need to mark it and also write the date on it because this is stable for a month's time. So then this needs, but this is temperature sensitive. You need to give this to the patient in a thermocol box, ice wrapped. And the patient also needs to store it in the door of the fridge for the entire tenure of using it. Yeah, so the next video is how to give an interferon subconjunctival injection. So it is given under topical anesthesia, instill a drop of paracaine, and then we inject the same pre-filled syringe. This has a concentration of 5 million international unit. Just go beneath the lesion subconjunctivally, not through the lesion. If it is a diffuse lesion, you can inject at multiple points and inject the entire syringe. It will form a subconjunctival bleb all around, and at the end instill a drop of beta-D. So for corneal OSSNs, that is OSSNs which are limited only to the corneal surface, you can only use topical interferon alpha 2b in a dose of 1 million international unit per ml. You will have to prepare the eye drop as I showed you, and it needs to be given 4 times per day. For a month's time, you need to review back the patient, and this will continue till we continue instilling the interferon 3 months after complete resolution of the tumor. So this was the corneal OSSN the patient had, and this was 3 months after with complete resolution of the tumor. So in cases of diffuse OSSNs, response with interferon is extremely good. This is one such case where you can see this gelatinous appearance on the entire ocular surface. So we treated this patient with interferon alpha 2B injection, monthly injection, as well as interferon eye drops. So this is 2 months after treatment. You can see there is complete resolution of the lesion. So the other option, as I was mentioning in the beginning, for these giant or diffuse OSSNs are clubbing them with a simple limbal epithelial transplant at the time of excision biopsy. That also prevents the limbal stem cell deficiency and the pseudopterygium formation. So this is from our institute. Next, coming to the plaque brachytherapy. Plaque brachytherapy we are using only for secondary cases, but in literature you will see there are indications for using it in primary cases as well. But in all cases of base positivity, that is whenever there is a scleral involvement by the tumor, we are using plaque brachytherapy using ruthenium-106 in the post-op period. And also this was a case of in a xeroderma pigmentosa patient. This was a recurrent ocular surface squamous neoplasia with a scleral fixity. That is, there was an intraocular extension. We did a plaque brachytherapy, and this is the fourth picture. This is at 3 months post-op. The entire lesion has resolved. So to summarize whatever we learned in the last 2 presentations, the key features in diagnosis ocular surface squamous neoplasia are it occurs in the interpalpebral region. The epicenter is at the limbus. Look for feeder vessels, look for keratin, look for pigmentation, look for intrinsic vascularity, presence of a corneal component, rule out intraocular and orbital extension, rule out any regional lymphadenopathy. Corneal OSSNs appears as sheet of cells with ground glass appearance with heaped up or fimbriated edges, so please don't miss them. If posterior extent of any lesion is not visible on clinical examination, please go ahead and perform an imaging to rule out an orbital extension. The typical finding of OSSN on an ASOCT is hyperreflective thickened corneal epithelium with an abrupt transition to normal epithelium. Wide excision is the preferred modality of treatment for localized OSSN. So we should not go back with this impression that interferons are better even for these localized variants. No, still wide excision biopsy forms the mainstay of therapy along with cryotherapy. Indications for topical interferon alpha 2B therapy are corneal OSSNs, where it is used for immunotherapy. Diffuse OSSNs, where basal diameter is more than 15 millimeter or more than 180 degree of limbal involvement, where the lesion has a flat configuration for immunoreduction. If the lesion doesn't reduce completely even after interferon, then you can go ahead and do a excision biopsy. Margin positivity. So in any case, whenever you see a carcinoma in situ or a severe dysplasia in your histopathology report for the margins, you need to give a 3 months course of interferon alpha 2B for immunoprevention in these cases. So coming to the dosage of interferon alpha 2B, only corneal OSSN treat with topical interferon alpha 2B 1 million international unit per ml. For a lesion with a conjunctival component, treat with both topical and subconjunctival interferon alpha 2B. Topical drops need to be continued for 3 months after complete tumor regression. OSSN with intraocular extension needs extended enucleation, or if you have facilities, you can also go ahead with plaque brachytherapy. With orbital extension, you need to do a orbital exenteration. Plaque brachytherapy is effective alternative to enucleation in cases with residual scleral OSSNs or best positivity after tumor excision. Thank you. My acknowledgement to my mentor, Dr. Swati Kaliki, for teaching me ocular oncology and for sharing few patient photographs. Thank you. So we will take up the questions at the end. I will request Dr. Dipankar to give his talk on histopathology of conjunctival tumors.